session. And just at the outset, I'd like to remind everybody in the room to please turn off your mobile phones, or at least put them on airplane mode so that they don't interfere with the sound recording. I want to welcome everybody here this morning, our witnesses in particular, those watching and committee members. For this morning's session, we're engaging with representatives of the health workforce who will outline their vision of health service reform. Health professionals, including nurses, doctors and non-medical support staff, are the beating heart of our hospitals and our community health services, as we know. As Professor Keane emphasised in last week's session, reform programmes need to achieve buy-in from members of the public and from staff, and that's critically important, and I think it's a message that's coming through from a number of the different witnesses that we've had to date. Our first meeting this morning will be with the Irish Congress of Trade Unions. And then at 10:30 we'll meet with representatives of the IMO, and finally at 11:30 we'll meet with representatives from the Irish Nurses and Midwives organisation. I'd now like to welcome the officials from Congress: Patricia King, General Secretary; Liam Doran, General Secretary of the Irish Nurses and Midwives organisation; Paul Bell, Health Division Organiser in ICTU; Terry Casey, General Secretary, Medical Laboratory Assistants Association; Eamon Donnelly, National Secretary, Health and Welfare Division of Impact; Liam Burney, Industrial Officer, Public Sector, Irish Congress of Trade Unions. Just a formality that I need to go through at the outset. I wish to advise the witnesses that by virtue of Section 17(2)(1) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. If you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise nor make charges against any person, persons or entity by name or in such a way as to make him, her or it identifiable. Finally, members are reminded of the long-standing ruling of the Chair to the effect that members should not comment on, criticise or make charges against a person outside the House or an official by name in such a way as to make him or her identifiable. So I understand that both Ms King and Mr Doran will be making opening statements, and I'd now like to invite Ms King.
Thank you very much, Chairperson. So Congress is pleased to accept the invitation to address the Oireachtas Committee on the future of healthcare. The establishment of this Oireachtas Committee and the intended focus on formulating a long-term vision for a reform public health service is a positive and welcome development. Congress has made a detailed written submission to the committee, and my comments and the statement to be made by my colleague, who's chairperson of the Congress Committee, Liam Doran, are based on that submission. The views expressed in our submission to the committee have been developed in consultation with our affiliate unions. However, the Irish Medical Organisation, the IMO, has independently developed a strategy for the organisation of the health services, and as you have mentioned, Chair, they will be giving their evidence in the next session. You will have noted that in our submission we refer to the fact that over the last 3 decades there have been several proposals to reform or overhaul the public health service. However, it is clear that real transformational change has not occurred, and we continue to have a dysfunctional system in which the perverse incentives that encourage private over public practice continue to persist. The failure to bring about real transformational change has also had a very demoralising effect on staff within the service. There is strong evidence of a developing and growing culture of restructuring fatigue. It is for these reasons that Congress believes that the establishment of this committee presents a real opportunity to begin a programme of reform that should begin with a declaration of intent that, over time, we will move to a universal, fully integrated, single-tier public health service that guarantees access and quality care regardless of income. In our submission, we have argued that the public health service should be funded through a progressive taxation system, At a minimum, the service should be allocated dedicated funding of 10% of GDP per annum, with a further recognition that significant additional capital spending will be required in some years. It is crucial that as part of the reform programme, over time the state will cease to subsidise all forms of private healthcare provision. We strongly believe that the development of a network of public, locally based community healthcare centres is vital to the future restructuring of the service. For the vast majority of citizens, the first point of contact with the public health service will be these centres. These centres should provide an expanded range of clinical and diagnostic services and will lead health promotion campaigns in the communities in which they are based. The network of public hospitals will continue as a vital cornerstone of the public health service, but the role of the public hospital will be refocused, with some services devolved to the community health care centres. Vital to reform of the health service will be a move to a team-based approach to patient care, which is consultant-delivered, and where all hospital staff are respected and enabled to perform tasks appropriate to their qualification levels and competence. The increase in the number of older people living longer lives is the biggest challenge facing our public health service. This challenge is such that it will require the state to reverse its current policy of privatising elder care and re-engage as the principal provider of healthcare services for older people. The incidence of mental health disorders continues to rise and demands a renewed commitment to deliver in full the proposals contained in the Vision for Change strategy already published. Not-for-profit organisations currently provide the bulk of health services to people with disabilities. A small number of highly publicised failures have highlighted the need for better oversight and a focus on quality assurance and patient care. A strategy of providing services in community-based settings must be part of an overall approach to the care of people with disabilities. And finally, the committee must accept that moving to a universal, fully integrated, single-tier public health service presents a number of workforce planning challenges, not least of which is understaffing. In designing the new system, full regard must be had for appropriate remuneration, reward and recognition systems and other conditions of employment, such that the Irish public health system is ultimately viewed as the employer of choice and is capable of attracting and retaining the most talented staff. Thank you, Chairperson.
Very much. Mr. Doran, please.
Thank you very much, Chair. Colleagues, it is the view of Congress that there is a growing consensus amongst Irish society that a single-tiered public health service which treats all citizens equally is in the common good for communities and our economy. And Congress, I would remind you, represents 750,000 workers and their families and has debated this issue of health extensively over this last number of biennial conferences. We also believe there is significant unease about the current two-tiered health system where money buys you quicker access to many services. And there have been many examples of that. However, despite the many limitations with accessing our public health service, patients report a very high level of satisfaction with the quality of care and treatment they receive when accessed. This high level of performance, once the public health service is accessed, must be maintained as we transition to a public health service which is resourced, structured and available to all citizens equally. Access and equality must be the two measures against which progress is measured. Against this background, Congress wishes to stress that the transformational change required must be commenced against a number of guiding principles, including the change to a single-tiered universally accessible health service will require far more than a decade. The change process must involve long-term multi-annual commitment for the provision of ring-fenced core funding for the public health service at a minimum of 10% of GDP, as Patricia has said. In addition, there will be a requirement for a significant capital programme to improve existing infrastructure and provide for new services. All funding should be provided through a system of progressive general taxation, with a declaration that the state will, over time, cease to fund or to subvent any form of private healthcare provision. This will require the phased elimination of all tax reliefs for private healthcare insurance and direct subventions, i.e. to existing private nursing homes. Another principle of the programme must be that all existing public health services are maintained and, where necessary, enhanced until the alternative models of service, with much greater emphasis on community-based services, are established and fully operational. The programme must also lead to a simplified, integrated and readily understood organisational structure with clear lines of accountability and transparency. And the single-tiered public health service must also be an employer of choice, offering all staff the opportunity to utilise their skills and talents in an environment which encourages innovation, autonomy and excellence. In relation to primary care, a cornerstone of a new health service must be universal eligibility for all health services, beginning with primary care, provided by directly employed health professionals. Staffing should be on the basis of 7/7 opening and centred on a team approach. The public must access the full range of health professionals who can cross-refer from one colleague to another based upon the needs of the person presenting for support or care. There can be no artificial structural barriers to a fully integrated primary care service. Such services available on this 7/7 basis must be provided on the basis that they can offer sufficient diagnostic and other support services so that the majority of persons attending can have their needs met without referral to the hospital or secondary care service. The shift to primary care will require, in addition to investment, a massive reorientation, not only of health professionals and staff, but equally the general public. In that regard, services must be capable in a seamless fashion, without lines of demarcation or limitations to access, of ensuring all health professionals are fully utilised, chronic disease can be managed away from the acute hospital, vulnerable people can access care, advice, support and guidance near their home, and significant investment in managing lifestyles in order to maintain positive health. It has to be noted and accepted that a public health service must be enabled and resourced to promote the maintenance of good health within the community and not just be left to deal with ill health and poor lifestyles. Acute hospitals. Congress must state at the outset that an immediate requirement within our existing public health service is a need for additional acute beds in a number of locations across the country. As we indicate in our written submission, the latest OECD bed-to-population ratio confirms that Ireland at 2.8 is significantly below the international norm of 5 beds per 1,000 of population. In essence, we have currently the perfect storm of too few acute beds to cater for demand, with wholly inadequate primary care services, which might, if they were resourced, provide a viable alternative to hospital care. In the context of a major investment programme to deliver the required additional acute beds, many of which can be 5-day or day beds to reflecting changed models of care, we also need to transform the role played by senior clinical decision makers, consultants, who should be employed to work exclusively in our public health service. The transformation programme, which should begin immediately, must see consultants on new contracts rostered over an extended day on a 7-day-week basis. This will, in turn, require a significant number of additional consultants in the core specialisms of medicine, surgery, paediatrics, obstetrics and emergency medicine. While moving to this consultant-delivered service, with less reliance upon non-consultant hospital doctors, there must be a significant reconfiguration of the roles played by other health professionals to optimise their contribution to patient care. This, as we have said, with regard to primary care, must involve more autonomous roles, cross-professional referrals and greatly enhanced team working. In the context of structures, Congress wishes to broadly welcome the establishment of the 7 hospital groups and the potential it offers to provide optimum patients' pathways, minimise duplication and streamline decision-making. However, Congress also believes, in the context of commencing this transformational programme, no existing acute hospital service can be discontinued unless or until an alternative service which enjoys the confidence of the public is readily accessible and available. Care of the older person. In the context of this country's demographics, we face 2 major challenges with regard to the provision of services to older people arising from the following. It is a fact that the number of senior citizens will steeply increase over the next 25 years, i.e. there has been a 21% increase in the number of persons over 65 since 2010 alone. And, linked to this increase, the number of older persons will be a significant increase, estimated 5% per annum, with the number of people presenting with multiple chronic conditions requiring ongoing intervention and care and support. And if I may at this stage just remind the committee, the number of people attending emergency departments went up by 5.3% this year to date. The vast bulk of those are frail elderly, and that is going to continue and increase unless we provide alternative pathways for those people to present to deal with their changing chronic conditions. However, regardless of how effective we make primary care services, it is a reality that long-term care will be necessary for significant numbers of our senior citizens. In that regard, Congress is absolute in its belief that the state must declare that, over time, it will return to being the main direct provider of long-term residential care for older people. This will require significant state investment in terms of physical infrastructure in residential surroundings. All monies currently spent on direct state provision to private nursing homes, which can be estimated up to 20 million a week or over 1 billion per annum, should be phased out and redirected into public direct provision. Mental health. In relation to mental health, Congress must begin by highlighting its concern that both budgets and services have been severely cut in recent years. Furthermore, it would appear that funding earmarked for mental health has, for various reasons, been utilised in other areas of our public health system. As recommended by the WHO, it is imperative, as we transition to a single-tiered service, that funding for mental health be set at a minimum of 12% of the total healthcare budget. In addition, service provision, as part of the transition, must be integrated within primary care. It must be accessible by the service user on a 7/7 basis and in major urban areas on a 24/7 basis through dedicated staff in major emergency departments. I think we all know, Chair and colleagues, the problems that mental health is presenting at the moment, the hidden hurt and damage it's causing. Congress also believes that, in properly resourcing mental health support services, necessary funding must be provided for preventative programmes. In addition, we must also recognise that a wider range of professional staff, including teachers, both in schools and colleges, as well as all health professionals, must have training with regard to identifying early signs of mental health difficulties. Disability services. Congress must ask the Committee to recognise, acknowledge and accept that the funding for disability services in this country has been subject to major cuts over the last 7 years. This has been done in a way which has had a major impact upon the quality of services available and the range of services that can be accessed in different parts of the country. This negative development has also been exacerbated as many services are provided by a range of entities which, while independent, rely almost exclusively upon state funding, Section 39 agencies, for example. It is the view of Congress that all disability services should be provided through direct provision with directly employed staff and in a manner which ensures that access to necessary support is available regardless of income and/or location. In making this point, we acknowledge the excellent work done by many not-for-profit organisations. However, in order to ensure equity of access and service provision, Congress believes direct provision is the model for the future. In the context of moving to direct provision, there must also be a continuing process of integration into community-based living and working opportunities for the disabled person, as we minimise the need for more traditional residential-type living environments. This must be provided for in the Capital Development Programme referred to earlier. Miscellaneous matters. Congress is acutely aware of the need for openness, transparency and accountability for those who manage and deliver to the citizens of this country. That is why Congress supports strong regulation to govern how all professionals practice. For the public to have confidence in those providing care, it is essential that clear regulatory standards apply and are seen to apply. Congress also recognises that any such service must be subject to constant review and examination by a wholly independent inspectorate. Workforce. Congress believes that an absolute cornerstone of a world-class, single-tiered, accessible health service is the employment of highly motivated health professionals and support staff. This must be within an environment where innovation is encouraged and staffing levels, as determined by an evidence-based approach, are maintained and guaranteed. In that regard, the transformation programme we are all seeking must recognise that a health service in the future must provide excellent remuneration, reward and recognition systems. It must also provide continuing development programmes so that staff are fully equipped for the ever-changing environment which will inevitably exist within every health service. Conclusion. The establishment of this committee and your report can, in the view of Congress, be an absolute watershed moment for this country and its approach to the provision of health services to its citizens. In that context, Congress believes that this committee should clearly state that an overarching goal of this process, in the interests of communities and the economy, is a move to a universal, fully integrated, single-tiered public health service that guarantees access and quality of care regardless of income. This can only be achieved by guaranteed minimum funding, in addition to significant capital investment, which must be removed from the uncertainty of the political electoral budgetary cycle. Congress recognises this is not an easy challenge, but it must be obvious to all of us that declaring a budget for the Health Service in October for the coming year makes forward planning all but impossible. The reality of our two-tiered system, with its illogical and contradictory incentives for key players, makes the journey to a single-tiered system all the more difficult. That is why Congress believes the change process will take at least 15 years and will require significant, sustained and increased investment. Congress also believes there is no option or alternative to this reality one takes into account existing contractual arrangements, existing service limitations, growing demand, changing demographics and societal expectation with regard to treatment. Congress also believes that this journey will require clear, determined and unambiguous leadership across the political system and within the health service itself. The goal must be that when we reach 2030, the citizens of Ireland will live in a country which promotes the maintenance of good health, but which responds to ill health in all its forms with efficiency, effectiveness, professionalism, regardless of socio-economic status or where you live. This is a demanding objective, but one that can and must be realised. Thank you very much.
Thank you very much, Mr Doran. Is it all right with you if we publish both of your opening statements? Thank you very much. Thank you. They were very comprehensive statements. I'm going to invite members to come in and ask questions, and if you could bank the questions, please. We'll take members in groups of 3. I'm starting with Deputy Madigan.
Thank you, Patricia King and Liam Doran, for your statements, and thank you for all of you for coming into the committee today to share your thoughts and views. I think it's very important that we hear those and that we listen to what you're saying because of the positions that you hold and the influence that you have. I see you're calling for a dramatic overhaul of the health system, which I think is laudable in itself, and I suppose I'm only playing devil's advocate when I ask a few of the questions just so that we can tease them out here for the committee. Spending 10% of the GDP on the current healthcare expenditure alone, and you talk about a restructuring fatigue as well, and you also mention about a timeline of more than 10 years. I'll ask just a couple of questions and you can answer them then together if you wish. I mean, I just wonder if that's really workable considering the high tax burden already felt by many families over the last number of years. And I suppose in relation to the timeline, with changes in technology and medical science, would that have to be rethought then at a future stage if we're looking for a longer period of time? Also, in relation to the centralised health system that you talk about, you mentioned that there's no room there, or my understanding is that there's no room there at all for private healthcare providers, for not-for-profit providers and community-based health initiatives. And I suppose I think there must be some way that we can learn from the experiences that they have had, or in some way include them in this system, because otherwise there must be some leverage there to use their skills and service, I suppose is what I'm saying. And I think it would be detrimental to completely have them out of the picture altogether. I note what you say about senior citizens. I think you're right in what you say in terms of perhaps looking for the state to be the main direct provider of care for them. I think it's going to be a big problem in the future. There's a lot of frail and elderly people there, and people are living longer, so it's something that this committee has to take into account. Also mental health, I think you have stressed that, and I think that's very important as well, that we take note of that. So that's really all I wanted to say, and thank you for coming in.
Thank you very much. Deputy O'Reilly.
Thanks, Chair, and thanks to all of you for attending this morning, and in particular to those who made the verbal contribution. I suppose, Liam, you mentioned the fact that we need to ensure that all health professionals are being fully utilised. That would suggest that they're not. I would tend to agree. I would tend to agree with you on that, but I wonder if you could elaborate on that, just in terms of the untapped expertise and the untapped resource that's there within the staff that we're not utilising at the moment. But along with that, obviously there are going to be challenges in terms of how we can best make use of those resources, because that does require a certain amount of reconfiguration, and there is, I would imagine, reconfiguration and restructuring fatigue and all that goes along with that. That's my first question. Secondly, I would be interested to hear the views, and I have my own views, as I'm sure you'll be more than well aware, in relation to how much value for money we get from the private sector for the services that are provided. We know, for example, there was 19 million euros spent on private ambulance services in 4 years. 6.3 million of that was spent in 1 year. While we have people who could and should be, I believe, providing that service publicly, but just to know your views on that. And finally, we've had a lot of discussion at this committee about what you might call the big bang versus incrementalism. Incrementalism is possibly more achievable, but you know, the big bang. How ready do you think we are, or how soon could we be ready for the kind of massive transformation that we've all, when we discuss here, I think we all know is very necessary. In terms of incrementalism, we've discussed whether or not you can take it piece by piece, whether or not you can reform the community, and then, you know, when that's finished, then reform the hospitals, and then when that's finished, move on. I'd just be interested in your views about how that's going to work. Will that work? Are we better to be massively aspirational and simply say, right, we're going to do what they did in Britain with the NHS, we're going to put the legislation in place and we're just going to move towards it? Or should we try a more incremental approach? Thanks, Chair.
Grant, thanks very much. Deputy Kelleher.
Thanks very much. Just to welcome the witnesses and thank you for their presentations and the more detailed submissions made to the committee as well. Questions, not necessarily my views, but just questions in trying to tease out the issue with regard to where we move from here in terms of developing a strategy to implement what we all hope we can achieve at some stage, which is a universal public health system accessible based on clinical requirement. And in that context, I mean, we have to live in a real world as well. It will have to be funded by your members' taxes, and you know, we have to get to a stage where we have a sustainable health system. Ms King referred to 10% of GDP, and I suppose it's an arbitrary percentage figure, but at the same time, you know, when the GDP is growing quite rapidly, as the case may be hopefully in the future, or shrinks rapidly, as was the case not so long ago, well then very quickly you have a system that doesn't or isn't underpinned on sound financial basis for longer term planning I'm talking about now. So the percentage might be something that I'd like more clarity on. Is it just an aspiration, or is it something that should be more clearly defined? When you talk about restructuring fatigue, Ms King, I suppose we have the establishment of the HSC 2004, and that hit the sands in terms of 2008 with the financial meltdown and the cutbacks to services. So, I mean, you could argue that the HSC didn't, you know, exactly hit the ground running, and was very quickly in huge difficulty in terms of financial resources. And I mean, that's the nearest we have to a public health system is the HSC in aspiration at least. But the broader issue that we have to try and address is within the HSC, within value for money, within what it is today delivering. I just want to ask a few questions, and that is primarily around the issue of staffing levels. And have we any comparison with other countries in terms of staffing levels, similar grades and professional competencies? Because very often I'm looking at figures, and I don't think I'm always comparing the apples with the apples. Sometimes it's apples and oranges, and you know, I think people are flexible in their views as to what actually is a comparator. So I'm just asking, in your research and in your efforts to try and come forward with a logical proposal in terms of how we develop a universal healthcare system, have you got statistics and figures on comparisons? Bearing in mind that some of our public health system is crossed over with a private healthcare system, so strip all the private out, like just on the public side of it as well, so that we could have a comparison. Mr. Doran, in terms of cost of delivery, you speak about one of the biggest challenges facing us is the whole issue of the demographic change, the life expectancy, comorbidities, many chronic illnesses and diseases, people living longer, but also living with chronic diseases and neurological illnesses, etc. And in that, you say that the public health system should be the one that delivers all the care for the elderly people over a period of time, obviously. And I'm just wondering, is there any cost to support that, or is that just an ideological view, or is it a fact that the public health system can actually deliver healthcare cheaper and more effectively than the private system in terms of how we presently fund it through the Fair Deal scheme? And I'm just wondering if we could just maybe get a bit of elaboration on that as well. And finally, in the issue of hospital capacity, there is no doubt that there's been a stripping out of beds per 1,000 in a particular acute hospital setting. And you say that that we've now arrived at the perfect storm with poor supports in the community, in primary care, life expectancy, demographic changes, and then the flip side is that everybody ends up in our emergency department on a trolley. And in that context, where would you start if you were implementing a plan over, as others have questioned, where would you start? Would you start at the primary care and start front-loading primary care investment initially, or would you consider just overnight that we transform the whole thing? Or, as you say, will take a 15-year period. Where would you think would be the priority in starting it to alleviate the immediate problems facing the acute hospital system or emergency departments and people on trolleys?
Right, thank you very much. If you could address those big questions.
Yeah, and there are a lot of questions in there. So my intention would be just to perhaps I myself will just hit a few of the points, and then colleagues who are, because all of my colleagues here are involved in different segments as well, and so we'll direct them as we can to try and get the best possible responses to you. But about
sorry, Patricia, if I could just ask everybody to be as brief as possible, both our witnesses and committee members,
okay,
because I know a lot of people are keen to get in.
So if I might say to you, in relation to Deputy Madigan and the 10%, well, actually, of GDP and the taxation system, and fundamentally, from our perspective, this is down to choices, down to government choice. We have a health sector, as we have described, which we won't repeat as we see it in the submissions we've made to you. It's about choices, and we believe that the private health system should not be subvented by taxpayers' money, and we're very clear about that. And it's, from our perspective, then, if you want to build the universal single-tiered system, then you make choices to do that. At the moment, it would seem that 70% of the health service is funded by government, and that's about 13 billion, the figures of 2014. So from our perspective, we're clear, and we're clear, as we have said in the submission, that we should not be having a system which has perverse incentive actually to uphold the private system. So we're saying that to you as now. You're very well entitled, anybody, to make a view, to take a judgment that that's ideological and aspirational and all of that. But the people in power who make decisions have to make the choices. The choices in the health sector at the moment is, if you have money, you get cared for quickly. If you don't, or you're not, your income level doesn't lend you into that, you wait. That causes people who therefore are on lower income scales to die or to wait longer being ill than somebody who has the ability to buy healthcare. That, to us, is a perverse system. And from our perspective, that's down to the establishment, the political establishment, policymakers deciding, is that the sort of healthcare system that they want. So that's to now, of course, Deputy Madigan, I have no doubt that in making those decisions, the politicians who have to make those decisions, particularly those who are in power, have to decide about all of the other liens on the taxation system and on public funding and so on. But that's really what it is basically down to. And as we know, particularly even if you just take Europe, other European countries have made different decisions, which is why I would say, just skipping briefly to Deputy Kelleher's question about have we facts, have we statistics, it would be desperately difficult actually to get anywhere other than start comparing apples with oranges when you compare the Irish health system, because it is quite unique, in fact, in the way it treats citizens in terms of inequality. and you can look at the French system, you can look at the UK system. There's much, much bigger equality preponderance there than there is in the Irish system. The issues about medical science and so on, I will leave to colleagues to do that. If I might deal with the issue that Deputy O'Reilly raised in relation to the private use, for instance, you mentioned the ambulance service. Well, I would just say to you that there are two things about this. There is either a myth or a belief that some, again, policymakers want to have, which is that once they outsource it, it's cheaper. Well, actually, there is absolutely nothing, and even if you look across the water, even very recently, lots of studies have been done. They're now starting to go back into insourcing because they have all agreed and believe now. We're usually about 5 to 6 years behind that thinking, but they now believe that because what you have in outsourcing is, number one, this country does very little monitoring of what happens to its money when it puts it out to the private sector to implement. The second thing is, Paul Bell, my colleague, would be very familiar, for instance, with the National Ambulance Service. I myself am very familiar with the ambulance service that's provided through the Dublin Fire Brigade here to the City of Dublin and the surrounding counties. And there was a very in-depth report done by Mazars, which I was involved in myself because I represented the firefighters for a number of years. And they would tell you, beyond comparison, the service that's provided, because it's provided on a 24/7, 365 days of the year, integrated with the fire service, they would tell you it's beyond doubt the cheapest. Now, there have been a plethora of both public servants and luminaries in the private sector who want to get their hands on that and want to hand it out to. And I would say, because they provide a service par excellence to the citizens of that, as do the National Ambulance Service, there will be very few who would be able to actually replicate the excellence of that service. But there's a push all of the time. Now, the level of price there, when you go in depth into that segment of the ambulance service, for instance, there isn't any way that the private sector who's in it to make a profit, could replicate the service that's been provided and the level of service and the standard of service. So I have to say, over many, many years, both in my position in ICTU and in Congress now, I have advocated this privatisation, this outsourcing is certainly not all it's cracked up to be, and the state does very, very little in the order of things, of following the money and seeing what the value taxpayers are getting in relation to that. On the final piece I will refer to is on the restructuring fatigue piece. Restructuring fatigue, Deputy Kelleher, in my judgment, is a real big issue in the HSE in particular. And what that does is, that leads to throughout the staff, regardless of grade, whether you're earning at the very top end or at the lower income levels grades, that leads to people believing that this restructuring is going to be an ongoing feature. And that actually, even as people, and this is a big challenge even that this group will face for any transformational propositions that it comes with, because what you have to do when you want to change a staffing in any organisation, you have to win hearts and minds. Well, you have a major mountain to climb when you have done that about 101 times and it hasn't worked. And the people who are supposed to be delivering the service will say to you, that happened before, we have no faith in that. And that is a big, big problem for the health sector. Big problem. Winning the hearts and minds of workers. And I have walked into, over decades, many, many canteens, many, many workplaces, and people will tell you now, it doesn't matter actually at that stage how good the manager is, or how wonderful they are, or what good ideas, because they've heard it all before. That is a big problem in the health sector. And the other piece is, to make restructuring work, the people, both at the policy development level and those who are charged with implementing it, have to have confidence and show confidence that what it is they're proposing will actually work. And they have to believe it. That's not the case at the moment. That's not the case at the moment. They don't believe it. They don't know whether it'll work or not. And they shift from one big idea to another big idea. But when you push it, do you think it's going to work? Well, they don't know. Because the basic fundamental principles are usually not changed, like, for instance, the perverse incentive. That's usually in there. So unless you grasp the major pieces of transformation that have to happen and show willing from the top to the bottom that this is going to happen, then people will just see it as another. And that is a big challenge for this committee, for us on the ground who are working with the people who work in the health service. And I mean, the health sector is 95% unionised. So from that perspective, we're in there all of the time listening to that. So after that, I will hand to my colleague.
Thanks, Patricia. I'll try and fill in the gaps that Patricia's left in terms of that now, in terms of the comment about funding. Okay? Let's have a clear debate about this. Ireland spends 10.1% of its GDP currently on health. 7% of that is through public and 3% approx through private out-of-pocket expenses, which the state subsidises in terms of tax allowances and tax rebates for health insurance. Okay? So those who can afford to pay get a better access to health service. Full stop. Irrefutable. It's as straightforward as that. So in the context of working out what we want to spend, what Congress is saying is that we have got to, if you like, tie up the money, direct public provision. If you want to have private health care, you can still have private health care, but the state is not going to subsidise it. It's going to have a fully universal access to health care where everyone is treated equally. And you're not asked the question, do you have health insurance or are you on a medical card? Because that automatically puts you in the old dispensary model. You go in one door or the other door. That's the reality. We've just dressed it up in nice clothes. So, I mean, that's where we are. The question of private practice is always going to be there. The NHS is lauded and so on. There's 12% of healthcare takes place in the private sector in the UK, right? So it's there, but people choose to do it and fully meet the costs and so on. All health professionals being fully utilised. Yeah, let me be very blunt with the committee and chair. You're right, organisational fatigue is set in, but there hasn't been reform in the front line over the last 10 years. The number of discharges at weekend in hospitals has not changed. We talk about 7-day working of hospitals. It hasn't changed. I faced the CEO of a health service executive in 2007, Professor Drum, who accused our people of elder abuse because our people, the people I represent immediately, were not prepared to do first dose antibiotic, IV fluid balance, phlebotomy duties in care of the elderly. So they were being sent back to an acute hospital to have an acute episode of care managed. Now, that was a grossly unfair charge, by the way. Congress has been sitting waiting for the HSE to engage in that very thing for the last 2 years, and they won't talk to us because of the siloed budget structures that exist in the HSE. Because in social care, to keep people in a long-term home while providing with first dose antibiotic, a blood transfusion, IV infusion, will cost the social care budget money. Now, it'll save the acute hospital budget money, but that's a different budget. So that's the level of myopic structuring we have now. So reforming health services in the community. Will anyone mind telling me why a public health nurse who knows the area, who knows the households, who knows the support infrastructure at families, who identifies Mr. Murphy or Mrs. Murphy as having a deterioration, maybe the chest respiration's gone up, pyrexia when they visit the home and so on, why they cannot be empowered to prescribe within protocols automatically without having to refer to a GP. Public health nurses have done a 4-year undergraduate programme, a year postgraduate higher diploma, 2 minimum years experience, and they will also have got to have done a prescribing programme to get there. So if you're not safe in their hands, then you're not safe in anyone's hands. And they're out there already willing and able to take that on board. And I'm also talking about community RGNs, and in care of the elderly, there should be that kind of protocol as well. That's what we mean by health services not being fully health professionals not being fully utilised. An OT should be able to refer to a public health nurse to a dietitian to a physiotherapist. All those things should be able to happen within the team environment without there being reference to, necessarily, the current practice of a GP as a trigger. GPs, essential part of the team. But when the condition changes, they need to be a new diagnosis, not when we're dealing with, within agreed parameters, the ebb and flow of managing a chronic condition. That's what we mean by underutilising, and that requires a mindset too, colleagues, of the general public, because we have a medical model of care here where, to a certain extent, if I go to the GP, if I don't get a prescription for a tablet or referral to the hospital, the GP was no good. He didn't listen to me, or she didn't listen to me. And that has got to change as well. So that's what we mean about fully utilising health. The big bang or incrementalism. To be honest with you, Chair and colleagues, with the contracts that exist at the moment, and people absolutely have a right to have those contracts honoured, I don't think Ireland can do a big bang, because we're not starting from the same place that we had in 48 in Britain or whatever it is. Right? We have to respect people who have contracts. But what we have to do is replace all those contracts incrementally with public-only contracts. Shall we shift over that 15-year period? If existing contract holders want to move into the new model, brilliant. But they can't be made to. They have to be respected and so on. We're seeing a court case at the moment go through for a certain grade of medic. And how much is that going to cost? And that's a contractual obligation, and that's life. So that type of approach, we'd love to do a big bang, but we're not starting from that place, we respectfully suggest, and so on. Staffing levels, and so on. Yes, Deputy Kelleher, we are absolutely bereft in this country of a willingness to accept best practice as determined by evidence already gone through in other countries. Okay? Whether you call it nurse-to-patient ratio, whether you call it midwife-to-birth ratio, whether you call it consultant. You saw earlier this week consultant short in the cardiac area because of and that negative impact and so on. We have said, I think, evidence base has got to produce and got to ensure our staffing. And in a public health service, let's be quite clear, if you want stable, consistent care, whether I'm in bloody Foreland and Donegal, or Rosslare in Wexford, or Skibbereen or Dundalk, you have to have norms of staffing that are consistent and maintained. And they can be a cousin of the pupil-teacher ratio, if you want to put it there. But that's how you guarantee consistent care. The hospital shouldn't be staffed, with respect, on the ability of 2 or 3 years ago they had a minister in the right place, if you get my drift. They should be staffed by virtue of evidence, and that evidence should be determined annually by the frontline manager, and we're working on that. And in fairness, we are. The good news is, in my little area of task force on nurse staffing, there is a task force in place. There is a maternity strategy which clearly identifies obstetric and midwifery